All right, well, let's transition to recurrent epithelial ovarian cancer. Although there are only about 24,000 cases, the death rate remains high. Fortunately, the survival, though, is relatively long. And I've tried to message that the prevalence is 10 times the incidence. So if it's somewhere around 24,000 per year, there's more than 200,000 women fighting in the recurrent setting. And so what happens is that they're diagnosed in advanced stage. Unfortunately, recurrences are common, and then they get treated over and over again. So I want us to begin by outlining the factors that predict or inform what that treatment in recurrent should be. It used to be platinum resistant, platinum sensitive. Now people don't like to use that term anymore. So what are the factors that determine treatment of recurrent ovarian cancer?
Well, I think you're reflecting sort of the evolution of the field, whereas when patients recurred about 15, 20 years ago, it unfortunately was a very short period of time, and we didn't have these multiple agents, multiple treatments. So we've done much better on that. But it also reflects the fact that I don't know if any of us really believe that for recurrent ovarian cancer patients we can cure any of them.
Right.
That's the challenge. And so we still need new agents and an effective way to approach them. But once the patient recurs, and I would say the other evolution has been because they can get treated so many times with different agents, that this whole concept of, 6 months is the cutoff, has sort of faded, because you could have a patient who has recurred at 7 months, technically platinum sensitive, but has had 7 lines.
Right.
That's going to be different than a patient who recurs 7 months after 1 line. So it gets complex. And so I think some of the factors now are how much pretreatment have they had.
Yes.
Okay. I do think the time interval does make it has some relevance. The type of recurrence, is this miliary disease, ascites, or is it sort of a solitary lesion? Those would, in my view, dictate what you might use. You might even have a surgical approach to some of those patients.
So you said number of lines of therapy, time from last platinum. We already said molecular signatures in the mix. And then the type of recurrence, which includes also, you didn't mention it, but lingering toxicities from prior regimens.
Sure,
You
absolutely.
didn't mention cell type. Does the cell type also factor into the treatment of recurrent ovarian cancer? And what I mean, the rare cell types, mucinous, low grade, and clear cell. Is the cell type important?
I think it's important to certainly recognize, absolutely. We've already alluded to this in terms of, PARP inhibitor, although BRCA mutations can be found in all types of histologies, most commonly seen in high-grade serous, clear cell endometrioid, much rarer in low-grade serous or mucinous tumors. However, for low-grade serous, these are very hormonally sensitive diseases. We sort of hearkening back into our initial discussion about primary treatment. We should also mention that the paper by Dave Gershensen's group at MD Anderson using an aromatase inhibitor as maintenance therapy in patients with low-grade serous carcinoma. I've definitely incorporated that into my practice for patients who are newly diagnosed, high-risk patients. But now we're talking about recurrence. Certainly aromatase inhibitors. There's some indication that perhaps MEK inhibitors might be usable in low-grade serous cancers, although I think the jury's still not out about that. For mucinous tumors are very difficult tumors to treat, and certainly next-generation sequencing might find a KRAS mutation, and there are KRAS-directed clinical trials around. So I do think that the histology is very important, yes.
So let's try to create some scenarios. The most common early recurrences are platinum sensitive. I'm sorry I used that term. The most common early recurrences happen more than 6 months after last treatment. Again, we're talking earlier recurrences. And many people would treat them with the platinum doublet. We have FDA-approved platinum doublets, 2 of them, with bevacizumab, carboplatin gemcitabine, based on this trial called the Oceans trial, carboplatin paclitaxel, based on GOG 213 with bevacizumab. There's another opportunity, carbo-PLD. Again, we asked you what the chemotherapy backbone was in frontline. We kind of agreed carboplatin, paclitaxel. What's the chemotherapy doublet backbone, again, in earlier lines of recurrence in platinum? Okay, see, I can't even help myself.
No,
In second line,
Responsive.
second line more than 6 months. What's
well,
the
I think,
platinum doublet?
I think you've mentioned all of them.
Which one would you use?
Well, it really depends upon the clinical situation.
I got it.
I know, it really does. So I still think all those factors that we just talked about, the level of platinum sensitivity, and that term still does come into how we think about it, because you wouldn't want to give patients with primary platinum refractory cancers platinum again. Right. So that term has to come into play. The underlying BRCA status or other DNA repair gene abnormalities within the cancer. Toxicities that you want to avoid. So that's really important now, because for patients with recurrent disease, you do have all these choices. So you're tailoring your doublets or triplets to the patient, but then the patient really has to tell you, like if she has a wedding or she doesn't want to lose her hair, kid's wedding coming up, or she has underlying neuropathy still from her original regimen, you're not going to want to use paclitaxel.
So at this meeting, Jacobus Pfisterer actually did a randomized phase 3 to try to help inform this idea. I told you we had carboplatin gemcitabine bevacizumab, we had carboplatin paclitaxel bevacizumab, and we had carbo-PLD. We didn't have a phase 3 of carbo-PLD bev, and by PLD I mean pegylated liposomal doxorubicin. So him and the Germans and other cooperative groups within the European network of oncology, G1 oncology trials, did a randomized phase 3 of carboplatin PLD bevacizumab, carboplatin gemcitabine bevacizumab, and carboplatin PLD was a little better. And then you talk about the convenience factor, carboplatin pegylated liposomal doxorubicin, at least the chemotherapy components every 4 weeks. And there's no alopecia, and less neuropathy, more hand-foot syndrome. Is that really now kind of level 1 evidence that the platinum doublet bevacizumab triplet should be carbo-PLD bevacizumab, or it depends on all these other things?
Again, I think you've got choices. So you really
But
have
you got to tell the audience what to do.
You've got choices, and you've got to engage the patient in this
Thank you.
discussion.
Yeah.
And you've got to also now think about, which we talked about, the BRCA status, the histology, her responsiveness to chemotherapy, her prior toxicities, but also her underlying medical problems. If she's got underlying cardiac disease, she has a congestive heart failure, maybe her LVEF is 40%. Probably don't want to use PLD because you have other options.
When they designed that trial, I was sort of a skeptic, saying, we already know these are active. What's the point of it? I actually think it's a very important study,
I do too.
because what it really did fill in my own practice, carboplatin pegylated liposomal doxorubicin is actually the favorite one with patients.
I'm trying to get her to say
For all
that.
the reasons.
I'm trying to get her to say
and in
that.
fact, when I mentioned retreatment with
But I think- but I
paclitaxel, they
I
just
still-
run out of the room.
Yeah,
But,
yeah.
but what's nice about that study, let me just finish, is that because it involved Bev, then because we didn't really have that data together, we had to piece it together. I think that helps.
Yeah. I think that, so if you're using bevacizumab and you're going to use carboplatin pegylated liposomal doxorubicin, it does complicate the issues around PARP inhibitor use in maintenance.